Service Lab is a community of service design doers and the service design curious. We meet up every few months to share our learnings with each other.
So for anyone that's new to Service Lab, we're going to do some quick introductions. So Service Lab is a bi-monthly event for service designers and the service design curious. We bring together various disciplines to kind of share learnings, go through kind of case studies, some really practical tools. We've had lots of different events in the past, some around kind of designing inclusively, some around policy design. We've had a few kind of in the health area as well, and many more. You can find some of our previous events on YouTube. We always record each event and put them up for more people to be able to enjoy. And Service Lab is run by a small team. So tonight, this event is going to be hosted by myself, Charlie and Otla. And we're just going to do some quick introductions to us, and then we'll tell you a little bit more about the event. So my name is Charlie Pothickery. My preferred pronoun is she and her. I'm a service designer with a focus on designing inclusively. I founded a small design collective called Inclusively, and we do work across the public sector, social enterprises, and quite a bit in healthcare. And I am currently sat in a mainly white room with some plants around me. I'm wearing a navy top and some bright yellow earrings, and I have long brown hair. I'm going to pass over to Otla now to do a bit of an intro as well.
Hi, everyone. My name is Otla, she, her. I co-organize Service Lab, and I'm here today with Charlie. I'm a service designer. I'm working in the public sector area, and I'm currently sitting in my bedroom, and I have a light blue background. I have a fringe and blondish hair, and I'm wearing a gray shirt. This event, the event tonight, it will be focusing on health and behavioral science, as you all know. And we have 4 great speakers bringing very different perspective to the conversation. So we will be hearing about integrating behavioral science into the design process, empathy and burnout in healthcare professionals, brains and body processes that impact human behaviors. And we will close with a session hearing about the world first LGBTQIA mental well-being platform that will encourage us to also to do a bit of like a reflective moment at the end. Without further ado, the agenda today will look like this. So we will have Dr. Rosie Webster getting us starting, talking about behavioral science in the digital health hemisphere. Then we will move to Dr. Lasana Harris. They will talk about how empathy it can be a double-edged sword to relieve and render human suffering. We will then have Dr. Silja Voolma. They will talk us about embodied humans, brain and body processes that impact human behavior. And we will close with Charlotte Fountaine. They will talk about CALDA and their journey and future plans. For each of the speakers, they will talk about around 10 minutes, and we will have 5 minutes questions after each of them. So feel free to start texting, writing all the questions in the chat. We will be hearing and picking some of them based on the amount of time that we have. Starting with the speakers, the first one, as I said, is Dr. Rosie Webster, that is the lead user researcher at Babylon Health and also a behavioral scientist. Rosie has a PhD in health psychology and over 10 years experience of conducting health research across academia, the charity sector, and digital health companies. So I will hand over to Rosie now. Rosie, when you start, please introduce yourself, describing what you look like and state your preferred pronouns.
Thank you. Yeah, my name's Rosie. My preferred pronouns are she, her. I have shoulder-length brown hair. I'm currently sat at my desk in a blue room, wearing a yellow dress and big white headphones. So if you're not looking, that's hopefully you can now picture me. Now, I am the lead user researcher at Babylon Health, specializing specifically in behavioral science. Now, over the past few months, I've been working to bring behavioral science into our work at Babylon to increase the positive impact that we have on people's health. So today I'm going to talk to you about what that looks like and how it's not always plain sailing. Now, at Babylon, our mission is to put accessible and affordable healthcare in the hands of every person on Earth. As part of that, we want to support people in their health, help them to make the choices that will keep them healthier for longer. However, getting people to change their behaviour isn't easy. If it were, we'd all be living perfect lifestyles and never do anything that was bad for us, which I know, at least for me, isn't the case. Even when we have good intentions, it can be a challenge to follow through on them. I'm sure many of us have planned ahead to make the healthy choice, such as ordering a salad or going to the gym after work, only to, in the moment, choose fries and a movie instead. Luckily, behavioural science can help to give us the best chance of success. Now, behavioural science is the systematic study of human behaviour. It includes the fields of psychology, behavioural economics, and many more. And what it gives us is theories and frameworks to help to guide our thinking and our research so we can understand problems more deeply. It also gives us scientific evidence of what's worked in the past. And lastly, gives us experimental methods to understand what works in our population, in our context right now. Now, just like design, behavioural science doesn't give us a magic bullet with all the answers, but instead gives us a process to make sure that we build the right thing and that we build it right. Now, this process can be overlaid on our existing research, design, and experimentation processes, supercharging the way that we already work. The first step in this process is defining what we're trying to change. Who needs to do what differently? Next, we need to understand that behaviour, to diagnose it. What's driving it? What's preventing it? This diagnosis helps us to decide which things we need to focus on with our solution. Once we have that diagnosis, we can then start to prescribe the solution. We try to find out which solutions have the best chance of success. Once we have that prescription, we can then execute on it, design and build it. Lastly, but also most importantly, we then need to evaluate whether that solution has worked. This helps us to learn and improve, and experimentation is key to this. So what does that look like in practice? I'd now like to give you some examples to show you how we're using some of the resources from the Behavioural Science Toolkit in practice at Babylon. Now, as I said earlier, behavioural science provides us with theories and frameworks, and these can help us with diagnosing the problem, understanding what's driving the behaviour. The COMBI model is a super helpful example of this, which I'm showing on the slide, but I will talk through. The COMBI model is a consolidation of lots of different psychological theories, and it's a super simple framework to help us to understand behaviour. The model proposes that in order for a behaviour to happen, people need three things: the capability, the motivation, and the opportunity to perform the behaviour. Now, capability might be about whether they have the skills or the knowledge they need, or whether they have the mental capacity to perform the behaviour. Perhaps they don't know what a healthy diet looks like or how to cook healthy meals. Opportunity is about the things external to the person. For example, do they have the resources? Does their physical and social environment support the behaviour? Perhaps they don't have healthy foods available in their local stores, or they can't afford them, or perhaps they eat that way because their family does. Motivation is the most important, but sadly also the most difficult to change. It includes conscious, reflective processes such as weighing up the pros and cons and deciding that it's a good idea to change your diet, but also automatic processes such as habits and desires, which drive us to keep taking the biscuits from the packet next to us because it's both easy and delicious. At Babylon, we use theories and frameworks like COMBI to structure our research and design work. We do things like structure interview guides and surveys using them so that we can explore each of the potential drivers of behaviour and work out what's most important. We also use them as part of our data analysis, providing a framework for organising and presenting our findings. And the image that I'm showing here on the slide shows how we've structured reports using COMBI to explain how the different drivers of behaviour are influencing it. This helps to make it super clear what we need to target with our solution, whether that's capability, opportunity, or motivation. Another tool in the Behavioural Scientist Toolkit is behaviour change techniques, which are evidence-based active ingredients that might be included in an intervention to change behaviour. There are various taxonomies of behaviour change techniques out there, but this one from Susan Mickey and colleagues at UCL, which I'm showing on the slide, is probably the most comprehensive. There's also an online tool, which I'm showing here on the right, called the Theories and Techniques tool, which tells you which behaviour change techniques are most likely to be effective for the behavioural drivers that you've identified. At Babylon, we use behaviour change techniques as a starting point for ideation. In sketching workshops, we obviously present our findings from any discovery research, and of course some how might we's, because we all love those. But we also present some hand-picked behaviour change techniques that we think might be most effective in changing the behaviour. And then the participants in the workshop are asked to include at least one of these behaviour change techniques in each of their sketches. Lastly, another major part of the behavioural science process is experimenting to test what works. So this allows us to learn and iterate and improve. You can see here that I'm showing on the slide, it's an example of an A/B test where we used the evidence to inform what we thought might be the most effective messaging at increasing the uptake of the COVID vaccine. And then we test that messaging that includes the behaviour and informed messaging against plain informational content so we can measure the impact on bookings. So we've seen that behavioural science gives us a process and how that can be integrated nicely into the design and development process. However, I just want to demonstrate that in practice, things are often a bit more messy. I'm going to briefly talk about a couple of things that I thought were true and how I've had to adapt to the fact that they are in fact false. The first one is similar to how we work in design. As behavioural scientists, our dream way of working is to always start with the problem, never the solution. This is our ideal. However, in practice, it's not always that simple. Sometimes the decision's already been made about what the solution should be. Sometimes you're working to iterate and improve on an existing solution. Sometimes you have to start with the solution. So I need to be prepared not just for the perfect use cases, but for the not so perfect ones too, because a little bit of behavioural science is better than none. With this in mind, I've created resources to support teams so that when they do start with the solution, we make that solution as good as it can be. I review the evidence on popular types of behaviour change interventions, such as habit formation and goal setting, and provide guidelines on the best way to design and implement those interventions. The bonus is that these assets are also valuable to people who've gone through the proper discovery process before deciding on their solution. So for those people, it gives them the cherry on top of the cake. The second thing I thought was true is that as a behavioural science team of one, I'm a unicorn who can do everything on my own. This is something that I've read and heard from a number of resources. Now, the ideal behavioural science team of one would both be an excellent qualitative researcher and a data scientist. They would have extensive knowledge of behavioural economics, as well as social health and cognitive psychology. They'd be excellent at designing and running experiments, while also being a great content service and UX designer. And all of this while also having the time to get buy-in from stakeholders. I'm aware that there are sometimes similar expectations in the design world, but as we know, unicorns don't exist. People can't be excellent at everything. Even if they are, they won't have the time to do everything. I personally have a deep knowledge of health psychology and I'm a good mixed methods researcher, but I'm not sure I'd have the capacity to do everything that's needed, even if I did have all the skills. As such, I've learned that collaboration and democratization is key. Learning from what I did when I was a UX research team of one, I'm working to democratize what I do. So I run training to give others the skills to embed behavioural science in their work. I'm also forming collaborations, working closely with our epidemiology and experimentation teams to bring all of our skills together, making us all more impactful. So to sum up, hopefully I've given you a bit of a taster of how behavioural science can be used to supercharge your design and development work. And there are lots of resources in the behavioural science toolkit that can help you with this. However, when doing behavioural science in practice, it's important to remember not to insist on that perfect process and work around what's already happening. And lastly, don't try to do it alone, democratise and collaborate. So lastly, there's just a few books here that I thought might be useful to you, but I can share the slides and there's links to all of them, but my 10 minutes are up, so I'm hopeful that we have time to move on for questions.
So has anyone got any specific questions for Rosie? If you want to shout them out, go for it. But also if you want to add them into the chat, feel free to do that too.
So you mentioned the evaluation side of things. What do you do if you kind of put in a behavioural science technique and it doesn't do anything? Do you take it out? Are there ones that you found are more successful than others? Like, what's that been like?
Yeah. So I've only been doing this at Babylon for a couple of months, so we haven't had many results of evaluations yet, unfortunately. But if something doesn't work, yes, we should consider taking it out. But what's important is having the qualitative research to complement it. So it helps us to get an understanding of if something doesn't work in an A/B test or any other kind of experiment, then we have an understanding of why. And that helps to inform whether we just need to tweak it or whether we should be removing it and trying something else, if that makes sense.
Yeah, that's awesome.
Great. And we've got a couple coming through in the chat. So we've got one from Scarlett that's around kind of what's the challenge like of getting a company on board with behavioural science? Have you got any tips, tricks to be able to kind of overcome that if it's a hurdle?
Yeah, so I mean, I've been really lucky in that the incentives are right for Babylon because, you know, our goal is to make people healthier. So, you know, behavioural science is helpful for that. But I think that it's about trying to show successes early on and also trying to use it to solve problems that, you know, the business has. So behavioural science, I apply it specifically to health, but it can be applied to lots of things. So by kind of saying, oh, you know, you have this specific problem that's really important to you, senior stakeholder, here's some tools that I can help you with to try and solve that, if that makes sense.
Great. We've got a couple more that are around kind of navigating the ethical minefield of what you do.
So it's a broader debate in behavioural science around ethics. Again, I'm really lucky because working in health behaviour change, we are most of the time simply trying to help people in making the changes that they actually do want to make on some level. So, you know, it's rare that we're kind of like using behavioural science to manipulate people into doing something they don't want to do. So I myself purposely kind of don't work in that area. I know that some people use behavioural science for various marketing things. Dark patterns essentially is born out of behavioural science. So, you know, it can be used for evil, as it were, in inverted commas. But I think when it comes to health, generally, it's easier to tread the line, I think.
And there's lots of different questions coming through, so I'm trying to just pull kind of key themes that are coming out. There's a few questions that are a bit around kind of training. So what kind of training do you do to kind of help get a team on board?
So making it as easy and accessible as possible, like so selecting the right tools for people that uses those easy and accessible tools. So I presented COM-B because it's one of the tools that I use in that training. It's part of a broader framework called the Behaviour Change Wheel. And I tend to do hands-on workshops going through the whole process of using that Behaviour Change Wheel framework. So people get to work together in little teams to choose the behaviour they want to change, kind of like doing their own quick diagnosis and making sure that they're getting the hands-on practice with it rather than me just telling them the science, which doesn't really help. So.
Great. I think there's a couple of questions coming up a bit around kind of titles, and I'm guessing it's a little bit more around the kind of collaboration that you've got between a couple of different team members. So there's a few comments around what's the difference between UXR and behavioural science. So I suppose if you could talk a little bit about kind of the different roles that you work with and how you see those as differing and how you make that kind of collaborative atmosphere work.
Yeah, absolutely. So in terms of how it differs from user research in particular, it's about bringing in those theories a lot more than you would otherwise. So rather than just gathering the data, also we're bringing in the theories of human behaviour a bit more than we might do otherwise, but also probably doing more secondary research and doing more literature reviewing and going back to look at the published peer-reviewed literature as well to kind of bring that in, as well as kind of bringing in those structured frameworks of thinking about things in a specific way and bringing in things like behaviour change techniques and stuff. But my main collaboration tend to be with other researchers, with the experimentation team, with product designers and service designers, and yeah, epidemiology, as I said. So yeah, I work with lots of different people, but I'm still based within the experience design team. So the majority of my collaborations are with them.
That was amazing. I think that's probably all the questions we have time for, but a massive round of applause for Rosie. It was a fantastic talk and just amazing answers to all of those questions as well. Thank you. I'm going to pass over to Otla, who's going to introduce our next amazing speaker.
Great. Thank you, Rosie. It was very great. There are already some comments in the chat, but also on Twitter. So it was very, very insightful. Up next is Dr. Lasana Harris, and that is an associate professor at experimental psychology at University College London. Dr. Harris completed his undergraduate education at Howard University in the States and received postgraduate training at Princeton University. He has held position both in the States and in the Netherlands before coming to UCL. Over to you, Lasana. Please, when you start, introduce yourself, describing how you look like and state your preferred pronouns.
Thank you, Atla. So I am Lasana Harris, he, him, and I'm sitting in my alcove where I've sat now for over a year. And there's hats hanging on the walls. I'm dressed in all black, and I'm sporting my afro. So I have no desire for a haircut, things opening up. So I am an experimental psychologist whose research focuses on what we call social cognition, which is thinking about other people's minds. And to study this phenomena, I integrate all of the tools of psychology, mainly experiments, economic games, but also all of the tools of neuroscience and physiology as well. And so what I'll do today is talk a little bit about empathy in the healthcare context. So it's not a service design talk per se. I'm not going to do a wonderful job like Rosie outlining service design, but instead I'll talk through empathy, what it is from a psychological perspective and how does it function in the medical fields. So imagine that you're walking down the street and you see up ahead that there's someone sitting on the floor whom you identify as a homeless person. That's a scenario where most of us might think empathy comes into play. Well, it turns out that what happens in that scenario are about 5 or 6 different psychological processes in a cascade, empathy just being one of those processes. So the first thing that has to happen is you need to appraise the situation as a helping scenario. So you have to think that the guy sitting on the street actually requires help versus doesn't. Once you've appraised it as a helping scenario, we make a prediction about what it would cost us to help in terms of financial resources, but other resources as well, specifically emotional resources. So is it going to be really taxing to help this person or not? We then make an inference about the other person's mind. We try to imagine what it is they're thinking and feeling. And in the case of empathy in this particular scenario, we might imagine that they're feeling suffering. And that's what motivates empathy, which I define as an emotional response. And so after we've thought about their suffering, we resonate with that suffering. And that emotional resonance is what we call empathy. Now, in the psychology literature, we're terrible with our terms. And so you'll see people refer to some of these other processes I've identified as empathy as well. But for our purposes, I want to just think about it as that emotional response. And that empathic response is usually associated with prosociality because it can motivate your helping behavior, if only to relieve your own distress, right? So if that guy over there is suffering and he's making me feel bad, if I help him, I no longer feel bad. That's a very cynical view. You could take the altruistic view as well and say, well, I recognize human suffering and that alone motivates me to relieve the suffering. The point is you have this cascade of processes when you enter a situation that might be a helping scenario. Moreover, the social context, as we call it, or the confines of the situation that you're in are also going to affect how each of these processes unfolds during this helping scenario. So what I'm going to do today is just talk you through a little bit of the processes that are the precursors to empathy, the prediction process and that inference process. And I'm also going to talk a little bit about how the social context matters, particularly for healthcare professionals, as they attempt to deliver care and support for their patients. So focusing on the prediction phenomena, one of the things that we discovered in psychology 30 years ago or so is that we don't always view people as people, right? We can encounter human beings and view them as something else. And one of the other things you can view people is as a statistic, as people tend to put it. So if I tell you that there are 100 starving kids and I need your donation to help them, those 100 kids become a statistic researchers have argued for 30 years. But if I tell you there's one starving kid over there, could you help that kid? That one kid is a human being, and that people are more likely to help that one kid versus the 100 kids. So in lots of experiments, we've seen this identifiable victim effect, it's called, where we help less people rather than more people. And the explanation has been this people as statistics idea. Well, a new way of thinking about this, if you take into account the prediction that I've just told you about, is that, well, it's not that people are a statistic. Rather, it's that 100 people is a lot of suffering. And as a human being, I can make that prediction. To try to imagine what 100 people suffering must be like is overwhelming. Because empathy, the experience of it is negative. If I'm resonating with your suffering, by definition, I am in an unpleasant state, as I mentioned before, that might help motivate your behavior to help people. And so we find that people don't help lots of people. They help the identifiable person because it's just less suffering. And because I'm making this prediction, I'm less likely to engage in the helping behavior because I predict a lot of suffering, and who wants to deal with a lot of suffering? Now, we've known for a really long time that people make predictions about impending social interactions. So if, for instance, I told you you were about to meet a recently released patient, and that patient was either a heart patient or a schizophrenic, you might get more nervous in the schizophrenic case, even though you haven't met either of these two people, because you're predicting what that interaction might be like. You're predicting that a schizophrenic might be unpredictable, for instance. And we know that these expectations we have about interactions depend on the same brain regions that govern financial predictions, for instance, right? So if I'm trying to figure out which of these two piles of cards is going to lead to a better chance of making a profit, it drives the same brain networks as if I'm thinking about an impending social interaction. So we know that people are making these predictions. So we did a bunch of experiments to demonstrate how messing with these predictions actually changes people's likelihood to help in helping scenarios. So in one case, we told participants, you're going to meet a recently homeless person who is either homeless because of a drug addiction, which is a stigmatizing condition where there's tons of suffering, or they're homeless because of unfortunate circumstances, right? They just had a series of bad luck events. And what we find is that in the drug addict case, people start, they anticipate more exhaustion from helping. So they say it's going to be much harder to help this person emotionally for me. And if we measure what we call dehumanization, so the likelihood that they think about the minds of these people, we find that they're less likely to consider the minds of the person addicted to drugs versus somebody who's just had a series of unfortunate events. This is all happening before they've had the interaction, right? So these are things people are doing proactively. And so we describe this as an attempt to short-circuit empathic responses, or as a proactive emotion regulation attempt, again, primarily because we're thinking about empathy in this emotion way. Now, we've done a lot of research with medical professionals looking at this issue because they're in a really unique scenario where they have to be empathic towards their patients. That's going to help them build a rapport and do a better job of diagnosing and treating their patient. But the actual treatment may not be pleasant, right? Even if I'm just sticking someone with a needle, it's not pleasant to inflict that much suffering. And we know that because studies that were done in Taiwan, for instance, with physicians demonstrated that the physician's brain response when they see someone getting stuck with a needle is very different from you or I who aren't used to sticking needles into people for a living, right? They have a very different reaction, a much more blunted reaction, presumably because as a physician over time, they've learned how to regulate their emotional responses when they see people suffering or in pain. Now, that presents a bit of a conundrum for medical professionals because on the one hand, you have to regulate your empathy. And we know this is important because in other work we've done, we show that your level of empathy as a nurse can predict your burnout. So if I'm experiencing more empathy as an emergency room nurse, I'm more likely to feel burnout. I feel a lower sense of personal accomplishment, etc., etc. So on the one hand, they have to regulate this response because it can be maladaptive. But on the other hand, I need to empathize with patients to make that connection. In fact, in the United States, the number one reason for litigation against medical care providers is a lack of empathy. When patients feel like they haven't really been listened to or heard or empathized with. So it turns out, therefore, that this prediction and this inference process is something that's very difficult to think about in this medical context where you're recruited for your empathy in British medical schools, right? You do an empathy test to get in. So they're selecting highly empathic people. But you must now learn how to be unempathic at certain periods, right? So it's not saying that you need to be unempathic all the time with your patients, but particularly where you're treating them, it's better to think of them as a broken machine in many ways. And so in a series of studies, we demonstrated how the environment of a doctor's office or that medical sterile environment actually serves as a cue to physicians to regulate their empathy. We did studies where we would take medical students to experiment rooms that we made to look like lounges with lava lamps and soft furniture, and other rooms we dressed up like doctors' offices and found that they did basic tasks like stitching, for instance, or suturing much better in the medical environment than in the relaxed environment. Moreover, if you do brain imaging studies with such people, you find that you get different brain mechanisms when you cue people to think about the hospital context versus a home context if they're imagining performing these painful procedures. So what that suggests is that this view we have of empathy should influence how we train medical care professionals. So currently there's something called a hidden curriculum in medical schools where they try to make you comfortable with death and blood and gore. And they do this by sort of having you dehumanize patients or bodies, right? So lots of medical professionals refer to patients by their disease or disorder rather than by their names. This is a tactic to sort of reduce empathic responding as well. But at the same time, empathy is important for sort of connecting to that patient. And so there's a lot of work happening now in psychology in this domain, trying to understand how can we train physicians to properly regulate their empathic responses, right? So that you save it for the occasions where it's helpful and necessary, but you can regulate it in other scenarios for your own mental health. And I think the pandemic has really brought this focus to light. There's been tons of anecdotes in social media from medical care professionals talking about the distress that they're suffering having to deal with so many patients. And so I think I'll stop rambling there and take questions.
That was amazing. Thank you so much. Again, if anyone has any questions, please start dropping them into the chat or feel free to jump in. We've probably got time for maybe 2 questions, I think. So we've got one question that's come through, which is from Thomas Deacon. It's around where do we stand on Bloom's position in Against Empathy, that compassion is more valuable than empathy?
Yeah, so in the psychology literature, we're having a bit of an internal debate. Some people have dissociated compassion and empathy. I find it really hard to separate them because I look at the brain and I don't really see differences. First of all, I don't see one brain region or set of activity underlying empathy. So empathy itself is a catch-all term for lots of processes, and I try to break these down at the beginning. And I see compassion as just another part of that catch-all term. So I don't see it as very separate. But the attack against empathy by Bloom and others is really because of results like I described, right? Where people, when they're primed with empathy, end up doing less pro-social things. I think mainly because of the prediction that people are making about what's going to be required to help. But I don't think we need to throw the baby out with the bathwater. So I don't take a stronger position as Bloom takes in that empathy is a bad thing. We should focus on training compassionate empathy. Absolutely not. I think we need both of them. I just think it's very situation specific. So I think there are certain contexts where empathy is exactly what you need. And there are other contexts where it isn't. And we need to do a better job of understanding what those differences are and training professionals to properly, if not experience, at least display the right psychological process in the right context.
That was a fantastic answer. I think we have room for one more question. And there's so many great questions there, but I think it'd be great to know a little bit more around how do you think we can encourage and enable empathy in others? I think that's a large part of what a lot of service designers, user researchers do. It'd be great to hear from your perspective as well.
Yeah, I think the first question is, do you really want empathy or do you mean something else? Again, we're so bad with terminology, right? We might be saying empathy when we mean a better understanding of your client, right? And understanding isn't the same as emotional resonance, the way I defined it. So I think we have to be really clear on what it is. And then if we're really clear that what we want is the empathy has this problem, right? In that the experience of it is negative. And so if I think I'm going to have to go talk to that guy and they're going to make me feel terrible, no human being really wants to do that. So you have to instead focus on the outcomes of the interaction, for instance, right? The fact that this is going to lead to a benefit. And I think then you can sort of assuage some of the fear, because again, people are making these predictions before they have the interactions, right? Like, I know if my friend calls me up and he's going through a breakup, right, it's going to be a difficult conversation. You can make that prediction. So dealing with those predictions, I feel like, is a way to encourage people to be more empathic without sort of boosting anything else, just sort of regulating the negative predictions that we're naturally making when we encounter people in these scenarios.
That was amazing and really just so interesting and intriguing. It's really helped to kind of question whether we do mean empathy at different kind of moments. So a big round of applause, and thank you so much for being a fantastic speaker. I'm going to pass over to Atla, who's going to introduce our next speaker.
Great, thank you, Lasana. And if you have a couple of minutes to spare to answer, and if you want to answer some of the questions in the chat, I think there are more and more coming through. Next up is Dr. Silja Voolma, that is a behavioral designer with 10 plus years of experience in researching, designing, and advocating for digital health innovation, and leads the research and design consultancy Behavioral Design Global. So we'll hand over to you, Silja, now. Silja, please, when you start introducing yourself, describe what you look like and state your preferred pronoun.
Thank you so much. Hi, everyone. My name is Silja. I am, my pronouns are she and her. I'm currently sitting in a room with white walls. There's some pictures on the walls, and there's a sofa behind me, and I have long brown hair, and I'm wearing a stripy shirt, black and white stripy shirt. And it's such a pleasure to be here, and it's such an honor to be on this panel of speakers. So thank you so much for inviting me. I am a behavioral designer, but like Rosie, I was trained as a health psychologist. So I come from a similar world of using health psychology theory in behavioral science and now in behavioral design, which essentially I would pinpoint as just the practice of implementing behavior change techniques in a communication context. So things that I work on a lot include designing digital health programs that create the communication experience for the user, or for different patient populations if it's a part of the healthcare service. So I've worked a little bit in my home country of Estonia with different national healthcare service design projects, specifically around precision medicine and personalized medicine, which tends to be very data heavy, bringing in genetic data, bringing in lots of different ethical questions. And I bring the kind of user perspective and advocate for the patient experience, the user experience in those spaces. And I have no slides today, and I actually, the topic I want to talk about today, I call embodied behavior. And to do this, I would actually invite you to, instead of looking at me, if you're sitting down, maybe close your eyes. If you're walking, please don't close your eyes. But I just want to invite you to take a deep breath. And the reason why I want to invite you to do that is to remember that your brain is attached to a body. So let's take that deep breath together. And I hope that this also provides a space for us today to consider how what is happening in our bodies often, if not always, colors, highlights, influences how we interpret what is happening in our world. So how our brain interprets our experience is usually derived from how the body is reacting to the environment that you're in, or how your body is reacting to it. I'm glad that I'm speaking about this after our last amazing speaker, because I think this actually connects to exactly the opposite point of view of how healthcare professionals are sort of trained to perhaps dehumanize their clients through their training in order to maintain their regulation skills. And on the other side of this, we have the patient, the user of a healthcare service, who wants to be seen, wants to be heard, and ultimately wants to feel safe. And so in my work in behavioral design in the healthcare space and also in digital health, something that we look at a lot is the mind-body dualism. And this is the dualism of the SCART that was, kind of put into, or that has defined our healthcare systems for generations, is now coming to a place of contention, or a place of no longer allowing people to have the experiences that they are yearning to have in healthcare spaces. People are coming with a much more intersectional understanding of who they are, and that's how they want to be seen and how they want to be heard as well. And so some of the processes that we think about when we are designing in the healthcare space really are about what happens to the person before they arrive in our service or in the product that they might be using that we're designing. And this is really important to really ensure that the experience of that user is one that takes into account the not just emotional state that they might be in, but also the physical state. When you think about that deep breath that you just took, think about the last time that you had an experience with a healthcare practitioner, with a healthcare service, or with a health topic that you might not be very familiar with. And think about how engaging with that topic made you feel, especially if you thought that there was some kind of an implication of that topic for you personally. Often we design in healthcare and we are so used to talking about health topics that we forget that isn't the common experience. And so when a person comes to us, to our services, to our products, they are likely to feel an activation in their nervous system. That might be in the shape of fear, it might be in the shape of anxiety, it might be in the shape of any kind of fight or flight response that could be freezing as well. So they might feel an inflexibility to respond, which is a particular state of the nervous system that happens after repeated trauma. So these states of the nervous system and of the body are important, really important to take into account in our communication at the first touch point with the user, with the patients. And this is something that in my work we look into a lot, and we try to move away from this mind-body dualism or any kind of dualism in public health specifically. So a lot of the world of public health is based on assumptions around what people should be doing rather than maybe what they're ready to do. And this in itself is another kind of dualism. Am I doing the right thing? Am I doing the wrong thing? Am I a good person for being healthy today? Am I a bad person for not being so healthy today? And all of these dual states create a dualism within the body as well. And so this is something that we can take into account when we are designing in the healthcare space, so that we can allow people to essentially relax, to take a deep breath, and to find some clarity and safety, and then hopefully empathy and compassion, and all the other things that we are already designing for, that they can then actually receive. When people come to us in these states of fear or states of anxiety, and they're already overloaded with information, especially in the healthcare space, you might be given a consent form that you are not even sure what it says. You might be given a brochure, you're not sure what it says actually, and you're in a state of overwhelm because you're worried about your health. And all of these considerations can be taken into account in our communication. One of the tools that I like to use in an integrated way with behavioral science techniques, as well as health psychology theory when designing these communication spaces in healthcare, is the 5E experience design model, which you might be familiar with, where we really try to create the holistic experience for a person and take into account what are their physical states that they might be in as they're coming into our space. So I think I will end there. I invite you to take another deep breath, and I'm happy to take some questions.
That was fantastic. Thank you so much. Really enjoyed taking a bit of a pause as well. I'm sure everyone else did. So go ahead and jump in with any questions. And again, stick them in the chat or unmute yourself and jump in if you want to as well. So we've got one question come through so far that is around a little bit more explanation around the 5D model, if that was the right kind of terminology.
Yeah, so it's called the 5E experience design model. I can actually have a link here to an initial reading on it if anyone wants to check it out. So it's a fairly flexible framework that you can use to design products and services. And what I find really helpful with it is that it allows the use of different types of theories and evidence base, as well as design methodologies and design principles in order to create this holistic experience for the user.
Great. And we've also got a couple more coming in. So there's one question from Dee that's a bit about your opinion on the health system supporting a holistic approach. And a bit of a reflection on that, thinking it's quite fragmented right now.
Yes, it is quite fragmented. I think it's like that in every country, and I think historically it does stem from actually Descartes' time of creating this mind-body dualism in our medicine, which essentially modern healthcare was born out of. And when I work with healthcare policymakers or governmental organizations, what I notice in terms of creating a more holistic approach in the healthcare system is that the barriers we face are a little bit at the data level that we look at. So what are the kind of success metrics, if you like, of the healthcare system? The most basic ones, of course, are a diagnosis, or do you have a diagnosis or not? And then essentially, are you alive or are you not alive anymore? And that's oversimplified, of course, but I do think that the importance of a diagnosis as a metric in the healthcare system keeps us from bringing a more holistic approach to it. So I think perhaps more discussion around how useful that metric is at this point and whether it's as much of a priority as we think it is, given we live in the age of chronic disease and behavioral disease, like risk factors, lifestyle diseases. So I think there should be some more discussion around that.
Amazing, thank you. And I think we've got time for just one more question. So Amy Hoop has got a question around content design. And do you think that some of the principles that you've talked about can and should be applied to kind of patient-facing guidance? It'd be great if you've got any thoughts around kind of content design in this sort of space as well.
Yeah, I'm actually designing myself at the moment a product that's very like content focused. And we're using conversational design to design essentially a conversation between genetic data donors and the biobank that they're a part of, and trying to deliver their sort of genetic risk information in this way. I think that these principles are especially important in content first types of services and products, or just the content, the communication, the actual words that you use. So being trauma informed is very important. Being intersectional is very important. Creating a safe space and creating clarity. I think that's a really, really big priority as well. So to reduce this information overload that we already have.
That's been really useful. Thank you. And I think keeping in mind that the fact that people might be going through that fight or flight, even when they're picking up a leaflet about something, it's been hugely useful. So big round of applause. Thank you so much for being such a fantastic speaker. I think there's a couple more questions that will maybe kind of filter through. If you're happy to answer some in the chat, that's great, but also no pressure too as well. So we're going to move on to our last, but by no means least speaker. So next up, we've got Charlotte Fountaine, who is a co-founder and COP of CALDA, the world's first LGBTQIA and mental wellbeing platform that provides weekly mindfulness sessions and daily peer support. Charlotte's going to be having a chat to us about why they started CALDA, some of their kind of biggest challenges and future dreams. And then also after a few kind of wrap up bits, CALDA will also be closing the event with some reflective, mindful moments. So I'm going to pass it over to the fantastic Charlotte now. If you could just start by introducing yourself with a bit of description of yourself and by letting us know your preferred pronouns, that'd be amazing. Thank you.
Hello. So yes, I loved those talks. And I'm excited to tell you a bit more about CALDA. So I'll set the scene. I'm Charlotte. I'm a she, her. I've got blonde, kind of peroxide dyed shoulder length hair. I'm white. I'm attractive, and I'm wearing like a black top and gold earrings. I'm in a white room, and then I've got a little shelf behind me, a little plant behind me as well. So I've set the scene for those of you who can't see me. I'm pretty excited to tell you a bit more about CALDA. So CALDA started quite recently, and this is sort of the first time that I think I've spoken about it, in a big talk setting. So I'm quite excited. So CALDA is an LGBTQIA mental wellbeing platform, and we provide weekly mindfulness sessions and daily peer support. We actually have a weekly mindfulness session happening right now, so I'm kind of like half checking my phone just to see that everything's going okay. So our theory of change is one of peer support and proactive self-care. So the features that we're developing encourage people to connect with others and gain mental health support within a community of people that have a shared identity. And how did me and the rest of the CALDA team come together and start CALDA? So my background is in design and also a bit in health evaluation. So last time I was at Service Lab, I was talking about health evaluation. So I worked for Mind. I designed Public Health England's digital health evaluation service. And then I wanted to really, implement some of those learnings in my own startup. I'm also a crisis counsellor for Shout. So I've been kind of working with large organisations, looking at how they improve and deliver mental health services. And I felt like there was space to create something outside of that system. With the NHS providing this amazing universal healthcare, what about if we need to create something tailored for a specific community? So that was kind of my approach. And then my co-founder, Al D, founded actually a festival called Midsummer 8 years ago. And that was born out of a need to support the trans community and the wider LGBT community with advocacy and funding and support. So Al is also a software engineer, and they're building the Cowder platform. And because the mindfulness is going on right now, I'm just going to send a quick text. So where was I? So when Al experienced their own mental health struggles, they found it hard to find the right support. So they actually trained as a guided meditation coach, so that they'd have the kind of tools to support their own community. So Calder is about scaling up that support. And then my third co-founder used to be the head of product at My Cognition, which is an NHS approved app supporting people with depression. And he also founded startups like TubeNav, which was an early tube map startup. So we got together, the three of us, on the Antler program, and we all wanted to improve mental health services and deliver them in a scalable and affordable way. And then we've had various people kind of join the team since then. So we've got 2 community moderators, we've got a guided meditation coach, we've got people helping us a little bit with technology and advice and things like that, and evaluation. So why did we actually focus on providing mental health support for the LGBT community? Our qualitative research showed that people in the LGBT community found it hard to find the right support. Mental health practitioners wouldn't always be understanding of somebody's trans identity, their bisexual identity, their polyamorous identity. So what we do is make sure that people are in groups with an LGBT practitioner, and there's other people with the same lived experience as them in the group. And that sense of shared identity has a positive effect on health outcomes. So the LGBT community kind of are disproportionately affected by mental health struggles and also stigma. So there was definitely a need to create something sort of specific. So in terms of the successes that we've had so far, since we started in October, we've grown from 0 Caldens to about 130 Caldens. So that's 130 people receiving daily reflection questions and weekly mindfulness sessions. So we've delivered over 20 mindfulness sessions to the community. Caldens have come from 3 different countries. And I think anecdotally, we're seeing that Calder activities improve mood, and then we're conducting a larger study to understand how Calder affects anxiety and depression long term. And some of the feedback that we've had has been brilliant. So checking in about my mental health and well-being have made a huge difference. And I love how it feels safer, because it is safer to do it with your own community, is what one user said about Calder, which is brilliant. And how am I doing for time, Charlie or Otla?
You've got probably 2 minutes or so.
Okay, awesome. So in terms of the learnings and the challenges, I think we're growing really quickly, and we're balancing product development with marketing and getting a peer support community going, and that's a real juggling act. And there's been a lot of learnings, but maybe that'll come out in the questions. So how can you get involved? You can sign up for the Cowder platform if you're part of the LGBT community. And I'll put a link in the Zoom side chat. We have weekly group mindfulness sessions. So if you want to kind of try before you join, then you can do that via Eventbrite. And then if you're just interested, then you can follow us on Instagram, or you can join our mailing list. So yeah, that is a little bit about Calder. Thanks so much for listening.
That was amazing. Thank you so much, Charlotte. We are going to open up to a couple of questions. So if you want to, again, just kind of shout them out or put them in the chat. But just to get ourselves going, I'd really like to know a little bit more about what are your dreams for the future of Calder? Where do you kind of want it to go?
So the dreams for the future are, I guess we don't want people in the LGBT community to be disproportionately affected by mental health problems. So we want this work to spread and to destigmatize mental health, and there to be greater understanding. So we want to be able to deliver mental health support to people across the UK and then go further, and just make this a kind of a safe space for people who really need it.
Amazing. Let's do another shout out for any questions for Charlotte. So we've got one through from Afsa. What has the impact been like so far?
So I think it is quite soon to tell. So we've kind of sent out our first batch of health evaluation. So we know that people who've joined CAUDA have varying levels of anxiety and depression, and then we're still yet to see what impact the daily reflection questions and the weekly mindfulness sessions have had on people's mood. And I guess the anecdotal feedback that we've had through surveys and through interviews is that people find all of that reflection really useful. But it's hard to say if it's having a big impact yet. I think that's going to come with time.
Another couple of questions coming through. We've probably got time for just one more. So just going to do a quick scan. So you mentioned working in other countries. This is a question from Caroline W. Have you found cultural differences as something that might affect the experience design?
Yes, definitely. I think it's all about the kind of cultural sensitivity. So we've had a few kind of people who found us on Google or through word of mouth who are in different countries, and they've just kind of joined up and been quite excited about being early adopters of CAUDA. So I think for them, they're almost getting the UK experience. The things are happening in the UK time zone, and their kind of understanding of that. But I think if we're actually going to, really move to, say, France, really move to, say, the US, we have to tailor our language. We have to find like cultural brokers in those spaces that can kind of connect us with the right people, because we're really growing in a sort of organic way through community. So yeah, I think it's just a case of doing lots of research about our users in different places.
Brilliant. Thank you so much. And I think I speak on behalf of the community of Service Lab that many people might want to kind of get involved and help out. So if there is anything that anyone can do, please do shout out or add into the chat. I'm sure you've got lots of willing kind of volunteers to want to get involved.
Awesome.
So I'm just going to do a quick kind of wrap up and summary of the amazing speakers that we've heard tonight. So we've learned about lots of kind of different areas of behaviour change and health. We heard from Rosie about some behaviour change techniques and how to use them as a start for ideation. We had an amazing overview of behaviour science kind of resources, how important that collaboration is, and a little bit about kind of those different roles and design disciplines and how you might collaborate with them to kind of best be playing in the kind of behavioural design space. We also heard from Lasana about the power of regulating an empathetic response. We learned that a number one reason for litigation in the US is a lack of empathy, and that there's this thing called the hidden curriculum in medical schools, which is around that kind of desensitization of medical practitioners. From Celia, we had a fantastic talk, and we learned about how we can think about designing in healthcare. And the fact that a lot of people, when they're first kind of interacting with healthcare, they're not as used to it as the people that end up working in it and designing in it. And a lot of people go into this kind of fight or flight mode, and how we can think about specifically around some content design, around experience design, to make sure that we're meeting people kind of where they're at, and the fact that they might be kind of frozen, or they might be just really not being able to kind of take in any information at that moment. And then we wrapped up with a fantastic talk from Charlotte there, learning about how to kind of build a service in an area where there wasn't a service before, really kind of enabling and finding out that there's kind of a gap and there's a need out there, and how to kind of scale that up very quickly from 0 to kind of 130 people across a couple of different countries as well. So a big round of applause again for all of our speakers. Thank you so much. It's been such a fantastic evening. We have a little bit of community news. So one of our amazing co-organisers is stepping back and becoming a co-organiser alumni. So Afsa, if you're able to give us a little wave. AFSA has been a fantastic part of the Service Lab team for almost 4 years. Has helped to organise and host some amazing events. So please send AFSA loads of love. We've sent her a lovely little gift from all of us, but please reach out and say thank you to her. And we also want to do a bit of a shout out for anyone that might want to come and join the Service Lab team. So Otla and I, and Rupert is still involved in the background a bit as well. We really love bringing kind of these fantastic voices like we've heard from this evening, and lots of different speakers to this wonderful community. So do let us know if you think you might enjoy it as well. Reach out to us on Meetup. And the next thing that we want to just have a moment for is also a bit of feedback on this format. So we tried something different, we experimented. Did it work? Did it not? Let us know on Twitter, let us know on Meetup, or let us know in the chat. Did you miss the slides? Did you actually go for a walk? Did anyone walk? But it'd be great to kind of hear any feedback on that. We're always trying to make sure that this event is as useful and enjoyable for as many people as possible. Thank you so much for joining.